Today we will be talking about something or a lecture that's very important in the industry. It is all about principles of oral diagnosis. As you can see here, it's the title, and we will start right away. So be with us in this lecture and wait until we finish it. It's about 45 pages, but it's a very interesting lecture. We have now intraoral examination. It is the most important part in dental point of view. Complete visualization with good source of light should be performed in a systemic regular method. The examiner must be familiar with the normal appearance of the intraoral structure and normal anatomical variations. We have here diagnostic set. Diagnostic position standing or low seated position, 10 and 11 o'clock. Avoiding resting on the arm, resting the arm over the patient's shoulder, avoiding keeping instruments on the patient's chest, upper and lower left posterior region. Upper and left posterior, this is left. Dentist should stand behind the patients. Upper and lower right posterior region, dentist should be at right side of the patients. We have also examination of the dental structures and examination of non-dental structures. And from this picture, we can see the examination of dental structures. We have the gingival crack, gingival crevice, and we also have the cemento-enamel junction, periodontal ligaments. We have the enamel, dentine, pulp chamber, gingival margin, and we also have the cementum, alveolar bone, and root apex. And here we have some terminologies and we have some jargons for the terminology of the dentistry. Examination of the dental structures, probing, percussion, and vitality tests. Number of present teeth, missing teeth and the cause, congenitally missing teeth, hypodontia, oligodontia, edentulous arch, U and V-shaped arch, well-formed or flappy regions, palatal vault, shallow and deep, bony, spicules, and tori, palate to evaluate for tenderness, supernumerary teeth, mesodense, distodense, distomolar, palamolar, supernumerary, supplemental teeth, dental caries, occlusal caries, proximal and buccal and lingual and cervical and root surface caries, chalky white or dark discoloration or cavitation. explore dental floss radiographs for proximal caries. We have to check for all of these. Attrition, abrasion, erosion, mobility, occlusion, check for molar relationship angles, classification of malocclusion over jet over bite, cross bite, open bite, and the crowding of teeth, calculus and stains, fractured teeth, enamel hypoplasia. On this picture, we can see the main structures of the mouth: lip, gingiva, teeth, hard palate, soft palate, and uvula, retromolar trigon, buccal mucosa, lip and cheek lining, tongue frontal, front 2/3, tongue on the floor of the mouth. In this slide, we will explain to you the gingiva, examine the marginal, interdental, and attached gingiva. We will discuss what is the marginal, interdental, and attached gingiva later. Comment on the color, contour, size, consistency, examine whether the gingiva bleeds spontaneously on palpation or on probing. Use a blunt-ended probe and walk the probe along the gingival sulcus gently and record sites that reveal bleeding from the gingival sulcus. Clinical anatomy of the gingiva. Here in this picture we can see it. We have the attached gingiva. We have the marginal gingiva, free gingival groove. Then we have the gingival margin, gingival sulcus. Then we have the interdental gingiva, the interdental papilla, and the caul, and the alveolar mucosa, and the mucogingival junction. Periodontal pocket. A periodontal probe is used to check periodontal pockets and placed on the gingival sulcus and walked gently along the circumference of the tooth along the sulcus to detect for pockets. However, a pseudo pocket formed by merely a gingival enlargement should be distinguished from a true pocket, which occurs as a result of loss of epithelial attachment and pathological deepening of gingival sulcus. We have here a healthy gum, periodontal pocket, and inflammation. The buccal mucosa can be retracted using a mouth mirror, with the mirror surface facing the mucosa. A gloved index finger can also be used to reflect the buccal mucosa for inspection. Normally, buccal mucosa has a deep pink color. The clinician should inspect for change in color, presence of swelling and patches on the buccal mucosa. The lesion should be palpated in order to assess its consistency, tenderness for parotid gland orifice, Stensel's duct, against the second maxillary molar. Floor of the mouth. The floor of the mouth is best visualized when examining the ventral surface of the tongue by asking the patient to the floor of the palate with the tip of his tongue, check for pooling of saliva in the floor of the mouth. The best method to palpate the floor of the mouth is by bimanual palpation. The Wharton's duct open through the sublingual opening, which lie on either side of the lingual frenum. That's the Wharton's duct, as you can see in this picture. And to continue, the Wharton's duct open through the sublingual opening, which lie on either side of the lingual frenum. Palpate the sublingual palpate the sublingual salivary gland, which is located at the anterior part of the floor of the mouth, and the submandibular gland that lies on the posterior part of the floor of the mouth. Evaluate presence of tori, cyalosis, cyalolites, nodal enlargement, and enlargement of the salivary glands. The floor of the mouth, frenum solid arrow, submandibular duct, orifice, broken arrows, that's the submandibular duct orifice or broken arrows, and the visible prominence of sublingual gland under the mucosal asterisk. Sublingual glands. I will read this slide to you. And you will judge whether it's a good slide and beneficial or not. Vestibule. The labial and buccal vestibules can be inspected and palpated by asking the patient to keep his mouth slightly closed. This can be achieved by asking the patient to initially open his mouth wide As the clinician places his index finger in the vestibule, the patient can be instructed to gently close his mouth and try to approximate his teeth, inspecting the vestibules for swelling ulcers, obliterations. Palpate the vestibules for tenderness and expansion of the cortical plates. Maxillary labial vestibule showing frenum, broken arrow. Note bulge over the root, canine tooth, canine eminence, long solid arrow, and adjacent depression, canine fossa, short solid arrow. A portion of the mucoconjunctival junction is marked with a broken line on the right. Again, a portion of the mucogingival junction. Just a small portion of the mucogingival portion. Is marked with a broken line on the right. Sebaceous glands are visible on the inner aspect of the upper lip. Sebaceous glands on the inner aspect of the upper lip. This slide is important. We have the tongue. To examine the dorsum of the tongue, the patient can be instructed to protrude the tongue forward, keeping the mouth open, to inspect the ventral surface. The patient is instructed to touch the roof of the palate with the tip of his tongue. In order to check the lateral borders of the tongue, a piece of sterile gauze is wrapped around the tip of the tongue and the tongue is drawn to the desired side. The muscular consistency of the tongue can be assessed by bilingual, bidigital palpation. Papillae, this one, with a long solid arrow, or late papillae, the first one here. Also note prominent submucosal veins, the second arrow, this one here. As you can see, the second arrow we have, and we can note a prominent submucosal vein. In this arrow, the upper one, the small one here, we can see a frictional hyperkeratosis, short solid arrow, but the most important one is the follate papillae. This one, the nearest line. On the other picture, as you can see, this one here, not this one, this one. Tongue dorsum showing contrasts of fungiform papillae, fungiform, against the background of colored filiform. And then we have a circumvallate papillae. Here, just one circumvallate papillae at the dorsum of the tongue, and there is a small line at this picture. You can see it. It's very far away from my finger, but it's a circumvallate papillae posteriorly. The lips, both extraoral and intraoral surface of the lips and the angle of the mouth should be examined. The extraoral surface of the lips generally appears pale pink in healthy individuals. The intraoral surface of the lips, labial mucosa, appears bright pink. Examine the lips for change in pigmentation, presence of ulcers, swellings, cuts, and clefts. The palate. Hard palate. The hard palate is generally examined by indirect visualization. Using a mouth mirror, the hard palate is generally pale pink in color. The hard palate is Bimanual Palpation and has a corrugated pattern in the anterior portion. Examine for changing color of the palate. Ulcers, midline swellings, swelling along the palatal surface of the gingival margin of the clefts. Soft palates. Soft palate in healthy individuals is reddish pink in color. However, the color may vary based on the vascularity. Soft palate is visualized by depressing the tongue using a mouth mirror as a tongue depressor. The soft palate is examined for swellings or ulcers. Generally, the soft palate is not palpated unless it's warranted, as it may cause a gagging sensation in the patient. Here in the picture of Edentulous Patient, we have a palate. Know the junction of the hard and soft palates, dotted lines. Junction between hard and soft palates. Maxillary tuberosity at the end. Thin, solid lines, arrows. Palatine fova, thin, solid arrows. Between the maxillary tuberosity, we have the palatine fova, or fovea palatine. Rugae is a broken arrow at the beginning of the palate. And we have an incisal. And this picture will show you that incisive canal, the greater palatine, neurovascular bundle, palatine glands, buccinator muscles, raphe, ovula, and palatine tonsils. In the other picture, we have, not this picture, this picture. Not this one, this one. We have incisive fossa, ovulae, etc. Tonsilles and the oral pharynx. The best realization of the oral pharynx in dental setting can be gotten by depressing the tongue with the mouth mirror and instructing the patient to say ah. The posterior pharyngeal wall, tonsillar pillars and uvula are examined. Posterior pharyngeal wall, uvula and tonsillar pillars examined. Note the presence of erythema, ulcers in tonsilles, erythema, ulcer, and exudates from the tonsillar crypt. Oral pharynx showing large palatine tonsilles with prominent cryptus. Note: debris visible within cryptus. On left. Debris visible on cryptus. On the left. Here we can see how that's visible on the cryptus. On we can allow so I was saying before there was some problem with the sound, but anyways, Tonsilles Pharynx, best visualized of the pharynx, the genital debris can be gotten by depressing the tongue with the mouth mirror or instructing the patient to say the posterior pharyngeal wall, tonsillar pillars, or the oviduct examined nose, presence of erythema, all sorts of enlargement of the tonsils and exudative from the tonsillar cryptus, oral pharynx, showing lateral palatine tonsil with the prominent debris visual. This on the left, short arrows, as well as the papilloma on the left base of the ruler. Basically saying that we have a cryptus, we have a tonsillis, and we have near it a papilloma. Cryptus, papilloma, cryptus, and uvula, showing the debris. Also, examine the patient, say, that he some investigation and examination histo and cytopathological examination. First of all, of course, we start with the histopathological examination, cytopathological, hematological, chemical, bacteriological, art of the imaging or radiographs. What should we use? When should we use them? What is the best one suitable for that case that we will have to use? The radiograph, extraoral and intraoral. Computerized tomography, CT scans, provides tomography section of a clear image without superimposition. Using contrast media, the plain radiograph or CT scan example, salivary duct cystography, hollow lesions such as cystic or blood vessels, arteriography. That one is called contrast media. With this salivary gland, cystography, etc. Magnetic resonance imaging. Magnetic resonance imaging. Is the ultrasound. Radiograph, conventional, computerized. Sometimes they are conventional, sometimes they are computerized. Intraoral, we have bite wing, we have periapical, and we have occlusal view. Extraoral radiograph, we have cephalometric radiograph, lateral and posterior anterior. We have OPG, and we have posterior anterior view of the skull, lateral view and oblique lateral view, and occipitomental view, Waters view, sinus view, and we have submental vertex view. Here we have some pictures showing us some things about the Stenson's conduct bacteria or this picture, the PA abscess, cyst, granuloma, periapical abscess, uninuclear, multilocular, radiocleft shape, osteomalaris, and odontogenic keratocysts, etc. Here we have leukemia. Also, we have the Edentulous cysts. All these are important cysts in the human body. Biopsy confirmatory tests. Biopsy is the removal and microscopic histopathologic examination for the whole lesion. Again, biopsy is a confirmatory test, removal and microscopic histopathological examination. Here we have it, of the part or the whole of the lesion. What are the indications of biopsy? We have 4 indications. Number 1, here we have oral ulcer that persists for more than 2 to 3 weeks, even after eliminating the cause. Persistent and white lesion, suspected neoplasm. Unidentified tissue mass, pathologic mass. Handling of specimen. The excised specimen should be immediately stored in 5 to 10% formalin. Types of surgical biopsy: incisional biopsy, part of the lesion, indicated for large lesions. The sample should be taken from the most susceptible area, should be relatively deep, large, and should include junction with normal surrounding tissue. Indications: other types of biopsy include excisional biopsy. Whole lesion, used when the lesion is small in diameter. Fine needle aspiration biopsy is an accepted and accurate technique for differentiating benign from malignant lesions involving lymph nodes, metastatic carcinoma of the lymph nodes, non-Hodgkin's and Hodgkin's lymphoma, Again, needle aspiration is just like an accurate technique for differentiating between benign and malignant tumors for lymph nodes, metastatic carcinoma of the lymph nodes, non-Hodgkin's and Hodgkin's lymphoma. Procedure: 21 to 23 gauge needle is inserted into the suspected lesion. Minute piece of tissue is sucked into the needle tip. Aspirated tissue is expressed onto a glass slab. Dried and rapidly stained. Stained smear is examined under the microscope. For exfoliative and brush biopsy, starting with exfoliative, cytologic is examination of the cells scraped from the surface of the lesion, or occasionally of material in aspirates of cysts. Brush. The brush is the technique that uses a round, stiff wrist brush to collect cells from the surface and surface layers of the lesion by vigorous brushing. Differential diagnosis and reasons for the biopsy. Histological evaluation. We have here in these pictures 3 cases of asymptomatic white mucosal lesions. Number 1, number 2, number 3. Benign. Number 1, hyperkeratotic. Number 2, early squamous cell carcinoma. And number 3, we have it here, candidiasis. We have here some mentioning of hematological, chemical, bacteriological, and serological examination. A complete blood count (CBCT) test measures the following: the number of red blood cells, the number of white blood cells, the total amount of hemoglobin in the body, and the platelet count is also usually included. Hemoglobin concentration. Normal concentration for adult male 14 to 18, and female 12 to 16, at birth 18. Erythrocytes count. Normal value for adult male 4, female 4.5 million per millimeter cube. That's for erythrocytes, and that's for the hemoglobin. When high numbers of RBC count is shown, that is an indication for a low oxygen tension in the blood. Congenital heart disease, congestive heart failure, pulmonary fibrosis, polycythemia, dehydration such as from severe diarrhea, renal disease with high erythropoietin production. That all cause high number of RBC. And some of these are counterintuitive, like the reduction in oxygen causing a high RBC, heart failure congenitally and congestively causing high right RBCs, pulmonary fibrosis, dehydration. Even dehydration can cause high RBCs. And the renal disease too could elevate the number of red blood cells in the body. Here we have low number of RBC can be a cause of blood loss, anemia, bone marrow failure. If the bone is exposed to radiation, toxins, fibrosis, or a tumor, then we have erythropoietin deficiency. That's another renal disease, but this time is causing a decrease in red blood cells count. Hemolysis, red blood cell destruction. Leukoplakia, multiple myeloma, malnutrition, nutritional deficiency of iron, folate, vitamin B12 or vitamin 6. Quick review, a high number of RBCs could indicate low oxygen congestive heart. This one, a high number of RBCs could indicate congestive heart disease, low oxygen pulmonary fibrosis. A low number of RBCs may include blood loss, anemia, hemorrhage, malnutrition. PCV, packed cell volume, in male is 40. Volume occupied by erythrocytes in 100 milliliter of centrifuged blood. If increased polycythemia, if decreased anemia, that's the PCV. Now let's talk about the RBC count. Normal value from 4 to 11,000. Neutrophil 40%, lymphocyte 20, then monocyte 2, eosinophils 1, basophils is also 1. So neutrophils, lymphocytes, monocytes, eosinophils, basophils. Increase in each of one of these white birds is an indication of some kind of a disease. Neutrophils, bacterial infections. Lymphocytes, viral infections. Monocytes, TB, malaria, hepatitis, syphilis. Eosinophils, allergic. And basophils, leukemia. A low number of white blood cells may include or may be an indication of bone marrow failure, for example, due to infection, tumor fibrosis, presence of cytological substances, autoimmune collagen, vascular disease such as lupus erythematosus, and sorry about those people walking around. Disease of the liver or spleen could cause a decrease in white blood cells formation. Also radiation exposure. High numbers of white blood cells, leukocytosis above 11,000, may include, here we can read high numbers, could be an indication of infectious disease, inflammatory disease, leukemia, severe emotion, physical stress, and tissue damage. We also talked about this before that in this slide. We have said something about white blood cells being elevated. Blood film examination is a survey of a stained blood looking for abnormal cells, which abnormal cells like abnormal white blood cells is an indication of leukemia. RBC may also show variation in size, shape, maturity, depth, and staining in the blood film. The size is indicated as normal, mono, micro, and microcytic cells. Depth of stain is normochromic, hyperchromic, microcytic, and hypochromic cells, small-sized with faintly stained because of less content of HB on examination of iron deficiency anemia. But pernicious anemia is macrocytic, hyperchromic cells with large size and deeply stained because of that it contains large amount of hemoglobin. Normal value of F serum vitamin B12 is 140 to 725. Vitamin B12 deficiency is associated with recurrent aphthous ulcers. Here is the aphthous ulcer in the oral cavity and recurrent candidiasis. G serum folate level, we have a normal value of 1.929. Folic acid deficiency is associated with recurrent aphthous and recurrent candidiasis, and it decreases in pregnancy, malabsorption, and diet deficiency. It is normal, the HESR, erythrocytic sedimentation rate in male, 15 to 0 milliliter per hour. It is a non-specific indication for a pathological change, arthritis, and malignancy. Investigation for sugar, for clotting factor disorders. Clotting time is 4 to 10 minutes. Prolonged clotting time in case of factor A deficiency as in hemophilia or factor 9 deficiency as in Christmas disease. PT prothrombi time 9 to 12 seconds. APTT, activated partial prothrombin time 30 to 40 seconds. Bleeding time 1 to 6 minutes. Prolonged at or as a result of abnormality in structural capillary von Willebrand disease or abnormal function. Number of platelet also affects the bleeding time. Platelet counts 150,000 to 500,000 per millimeter cube. Decreased number of platelets is called thrombocytopenia. Leukemia, aplastic anemia are both could cause thrombocytopenia. Blood sugar concentration used in the diagnosis of the diabetic patient, which is clinically reflected as dryness of the mouth and burning sensation in the patient. FBS fasting blood sugar test in the morning, fasting for 12 hours. A normal range is between 90 and 126 mg per deciliter, or 3 to 6 millimole. Random blood sugar 140 to 100. Oral glucose tolerance test and its advantage is of detecting diabetes at earliest stage. The patient is instructed to take 75-gram glucose before the test. Then blood is tested after half an hour, 1.5, and 2 hours. If two of these is above 200 milligram per deciliter, so the patient is diabetic. After 2 hours, blood sugar should not be more than 126, as if in the fasting blood sugar. Glycosylated hemoglobin, HbA1c, providing a measure of the average blood sugar over the preceding 3 months. The lifespan of erythrocytes. It's considered as an indicator for the degree of the control of the patient diabetic. Normal values up to 7%. HbA1c can tell you how high your blood glucose has been on the average year over the last 12 weeks. A normal non-diabetic HbA1c is 3 to 5%. In diabetes is about 6.5%. Controlled diabetes, not much glucose, not much glycosylated hemoglobin. And uncontrolled, we have diabetes that is more glucose, more glycosylated hemoglobin. And here we have many tests to test the chemistry of the body containing calcium chloride bicarbonate and magnesium phosphate, potassium sodium enzymes, alkaline phosphate alkylase, creatine kinase, ALT/AST, albumin, bilirubin, cholesterol, creatinine, globulin, glucose, protein, triglyceride, urea, and uric acids. We are almost finished. When you realize this, it can provide valuable information regarding renal function, liver function, metabolic disease, diabetes mellitus, the presence of protein or blood could indicate renal or bladder disease. The finding of bilirubin in urine could indicate liver disease. Bacteriological investigation, culture and sensitivity test swab may be taken from the area of microorganism that the microorganism is identified and tested for antibiotic sensitivity. Then we have a diagnosis, a differential diagnosis. The differential D or differential diagnosis. Comparative diagnosis in which the clinician mentally lists the diseases that could explain the general features of regional dysfunction. Walk-in diagnosis, presumptive, provisional, tentative. It is the most likely diagnosis in the list of differential diagnoses after eliminating the disease that are not justified by the diagnostic information. Definitive diagnosis. It is the correct precisional diagnosis that resulted after the confirmatory tests, like the histopathological examination and the diagnosis, determining the treatment plan. That's the definitive diagnosis. And also we do reassessment here, re-evaluation of the patient's symptoms and re-examination of the affected region at some time interval after treatment. Also we see the prognosis, the predict of the course, duration, treatment of the disease and its response to treatment after final diagnosis, if it was poor, fair, or good. This was a nice lecture. We enjoyed everything in this lecture, and it really gave us an overview of the whole principle of oral diagnosis. Thank you for attending this lecture and hope to see you in the next one.